We now come to this radiological staging of the mediastinum. We now discuss about the mediastinal staging in lung cancer. So we know that CT scan is important, PET scan is important, and eventually we need a pathological diagnosis. This is a very important paper which came from Heidelberg and which looked at 100 non-small cell lung cancer patients who had a mediastinal lymph nodes of less than 1 centimeter on the CT scan, and all these patients were systematically subjected to EBUS-TBNA, and malignancy was detected in 19 patients. So 19 patients could be upstaged as far as the radiological staging was concerned. Subsequently, the same group from Heidelberg looked at a very interesting cohort of patients, 100 patients highly suspicious of non-small cell lung cancer with CT scans showing no enlarged lymph nodes, there is no node more than 1 centimeter in size, and a negative PET. All patients underwent EBUS and subsequently also went a surgical resection. Malignancy was detected in these cases in 9 patients and missed in 1 patient. So again, even if you have a situation of a normal CT and a normal PET, you have patients, 9% of the patients were upstaged based on EBUS-TBNA. And therefore, based on these data, EBUS-TBNA, potentially operable patients with no signs of mediastinal involvement may benefit from the pre-surgical staging with EBUS-TBNA. Now we move, this is a very important trial which came from Yasufuku. It's a prospective controlled trial of EBUS-TBNA compared with mediastinoscopy for mediastinal lymph node staging of lung cancer. Patients with confirmed or suspected non-small cell lung cancer who required mediastinoscopy to determine suitability for lung cancer resection were entered into the trial. All patients underwent EBUS-TBNA followed by mediastinoscopy under general anesthesia. And if both were negative for N2 or N3 disease, the patient underwent pulmonary resection and mediastinal lymphadenectomy, a very important trial. Out of 190 patients which were registered, 159 enrolled, and 153 patients were eligible for analysis. The sensitivity, negative predictive value, and the diagnostic accuracy for mediastinal lymph node staging for EBUS-TBNA and mediastinoscopy was similar. If you look at these numbers, 81%, 91%, 93%, followed by 79, 90, and 93% respectively. No significant differences were found between EBUS-TBNA and mediastinoscopy in determining the true pathologic end stage in these group of patients. So EBUS-TBNA and mediastinoscopy achieved similar results for mediastinal staging of lung cancer as performed in this study, and EBUS-TBNA can replace mediastinoscopy in patients with potentially resectable non-small cell lung cancer. Later, another retrospective review from Yasufuku looking at EBUS-TBNA results in patients with potentially resectable N0 or N1 non-small cell lung cancer based on CT and PET. A total of 981 patients underwent EBUS-TBNA during this period, of which 163 patients met the study criteria. EBUS-TBNA upstaged 9 patients to N2 disease, but was falsely negative in the mediastinum in 7 patients. So in 5.5% of patients, there was an upstaging from N0 disease or N1. In CN0, EBUS confirmed N0 in 87 and upstaged in 7 patients. In CN1, EBUS confirmed N1 in 19 patients, downstage in 47 and upstage in 3. Therefore, EBUS-TBNA can accurately access the hilar and the interlobar lymph nodes in patients with potentially resectable lung cancer. Accurate assessment of CN0 versus CN1 by EBUS-TBNA may be used to guide induction chemotherapy before surgery. That was the conclusion that Yasufuku made in 2013. But I will also discuss with you the impact of N1 diagnosis in the subsequent slides. This is a systematic review and meta-analysis about preoperative staging of EBUS in CN0 and N1 lung cancer. 13 studies were analyzed, 7 were prospective. Mean prevalence of N2, N3 disease was 15%. That means EBUS would upstage patients by a substantial number of 15%. EBUS pool sensitivity was 50% in unsuspected N2, N3. It prevents postoperative upstaging, and the sensitivity is higher than radiological detection of occult nodal metastasis. Table will show these, the true positivities, the false positivities, the false negative, and the true negative. In time, I will not go through these data in detail. Now, again, you know, I spoke to you about the value of eBNA in staging. EBUS-TBNA also has an important diagnosis, important role in the diagnosis of lung cancer. And in this paper from David Fielding from Australia, he proposes that the same, that EBUS-TBNA can be used as a diagnostic as well in one sitting. And the way they did this here was they did those who had never undergone a bronchoscopy, that is a group A, and those who had a bronchoscopy or a transthoracic needle aspiration elsewhere with the primary mass, but that was not diagnostic. And in this, they found that the sensitivity for malignancy by EBUS-TBNA was 94% in group A and 95% in group B. And therefore, you know, with the expansion of EBUS-TBNA, a new guideline for its initial application in such patients could reduce the overall number of procedures. This was the proposition which was made in 2009. And over practice, we have seen in the last 10 years, this is almost coming into clinical practice, and several guidelines also support it. This is therefore, you know, we, along with Yasufuku, Dr. Vaidya published this review in the expert review of respiratory medicine, along with Yasufuku, about EBUS-TBNA in the diagnosis and staging of lung cancer. It's a day care procedure done under sedation. It's got a high sensitivity. Sampling of N1, N2, N3 nodes in the mediastinum is possible. You could also detect endobronchial tumors, and the same EBUS scope can be used to sample station 8 and 9 in the same setting, and thus completely stage the mediastinum in the same setting. The implication of N1 nodal metastasis, if you look at this staging, it's clear that the N1 nodal metastasis is very important, and the stage changes as the tumor size changes. And clearly you can see, you know, if it is T3 and if it is N1, it becomes stage 3A, and therefore N1 staging is extremely important. To summarize, diagnostic and staging with EBUS-TBNA is possible in the same sitting and is very efficient. EBUS-TBNA is routinely performed in the daycare setting with less morbidity. EBUS-TBNA and mediastinoscopy, as have been shown in the trial by Yasufuku and subsequently by many other trials, has a similar sensitivity, negative predictive value, and accuracy. In CT and PET negative mediastinum, it can cause a pathological upstaging using EBUS-TBNA. Molecular sampling is possible with EBUS-TBNA. I have not shown you the data in interest of time. And restaging is also possible with EBUS-TBNA. Again, in interest of time, I have not shown you the data regarding the restaging utility of EBUS-TBNA in restaging. So to summarize, when we talk that EBUS-TBNA and mediastinoscopy have a similar sensitivity, negative predictive value, and accuracy, it's important to know that the same procedure can be used on a daycare basis. You know, it's a very short procedure with a very low morbidity and low mortality, and it can be combined as a diagnostic and a completely staging procedure.
Thank you, Dr. Prashant.